This is the MyHeart.net podcast. This show is produced by Dr. Philip Johnson in conjunction with VitalEngine.com. Please welcome your host, Dr. Alain Bouchard of Cardiology Specialists of Birmingham, Alabama, at St. Vincent's Medical Center, part of Ascension.
Well, welcome to our podcast on CTEPH. And you would say, what in the world is CTEPH? Well, it's called also chronic thromboembolic pulmonary hypertension. It's a part of the group 4 in patients with pulmonary hypertension. And it actually happens to be a curable cause of pulmonary hypertension. So very excited about this. Excited also to have on our speaker row Dr. David McGiffin, who's a world expert in CTEPH, who's done multiple surgeries in patients with this disease. We have also Dr. Jason Guichard, who's a world specialist in pulmonary hypertension. So, Jason, welcome. Thanks for being here. So let's talk about numbers a little bit. I mean, if we talk about pulmonary emboli or clots in the lungs, we talked about that in one of our previous podcasts, which was the pulmonary emboli or the killer clot. We're talking about in the United States between 500 to 600,000 patients afflicted by a pulmonary emboli. That's about 1 in 1,000. Of these, I mean, we know it's a killer clot. It's a deadly disease. Sometimes it's missed or underdiagnosed. Maybe 60 to 100,000 patients will die from pulmonary emboli. So it's a very serious condition. Of these patients with pulmonary emboli, approximately 1 to 2% will develop this chronic condition, called CTEPH. We're not talking about a very large percentage of patients, but it's such a huge and very prevalent disease that overall it's probably around 5,000 patients that can be afflicted with CTEPH. And if we look at the operations that are being performed yearly, only maybe 450 surgeries for CTEPH are being performed. It's a very, very small number, which means a lot of patients are being missed or maybe undiagnosed. And this is why we wanted to do a podcast on this, because it's a curable disease and it's difficult to diagnose. So here we are. And maybe I could start with you, Jason. If we talk about pulmonary embolus, someone who has a pulmonary embolus or a clot going into the lungs, what is the normal process of the body resolving or dissolving this clot, and how long does it take to resolve it?
So yes, happy to be here. That's a great question. So everyone's heard of pulmonary embolisms, pulmonary thromboembolisms, so blood clots, usually traveling from the legs or other veins and then end up traveling through the heart into the lungs. This can cause lots of issues, all the way kind of from mild shortness of breath to death. There's definitely a gradient there. But once the blood clots get into the lungs, obviously for most patients, there needs to be treatment. Now, the acute treatment has been addressed elsewhere in our podcasts. As these, and one of the cornerstone treatments is a blood thinner. So as you might imagine, a blood clot is usually battled by a blood thinner. And as the blood thinners, get on these clots and into the pulmonary arteries, the clot will begin to dissolve. Now, the timing of that is, different and dependent largely on the clot burden, how well some of these, clot busters or blood thinners can get into the clot. But I've seen clots, dissolve within the matter of, say, an hour or two. All the way to, several hours or even days. You can get chronic clots, which are a little bit harder to, dissolve versus, kind of acute clots. So there's a lot of variability when it comes to the resolution of thromboembolism that's in the lungs. CTEPH, which is what we're talking about today, so chronic thromboembolic pulmonary hypertension, is still a relatively rare outcome. I think it's important, to kind of bring that up. Depending on the study and registry that's been looked at, it can be anywhere developing in about 0.5% to up to 3% of acute pulmonary embolism survivors. So it's a relatively rare outcome, but of course something that we want to miss because it is, highly treatable. Now, with these patients that develop this pulmonary embolism and the chronic thromboembolic pulmonary hypertension, you have a kind of a chronic fibrotic, flow-limiting organized thrombus within the vascular bed. So these are areas that were not dissolved by, either clot busters or by blood thinners, and form this kind of fibrosis, kind of very hard, flow-limiting kind of mass through the pulmonary arteries that are, basically undetoured by blood thinners. And then at that point, additional therapies need to be either considered or performed.
So approximately 96 to 97% of the patients will resolve their clot completely. But you have some patients that take a little bit longer. If you do, for example, VQ scans and you follow the resolution of the filling defect or what the clot caused, some patients will take up to 6 months before resolving their VQ scan or to become normal.
Yes, that can be true. Yeah, so this can take, in some patients can take, weeks to months to resolve, if it ever does resolve. And then some patients can be, literally in the matter of, hours to minutes, depending on, if they received thrombolytic agents or not. I've seen rapid turnaround and resolution of even large clots within and around the heart, even within, several minutes to hours. So I think a lot of it just depends on, kind of the composition of the clot, the age of the clot, where the clot is. But yes, it can be anywhere from, hours to, several months, for each individual patient.
So Alain, let me just make a point here that not everybody that doesn't resolve a pulmonary embolus ends up with CTEPH. But many patients who have an embolus, pulmonary embolus, still have symptoms, as you mentioned, that may go on for many, many months. And there will be patients with demonstrable areas of VQ mismatching. So there's still residual abnormalities in their VQ scan, but they don't have CTEPH. And so anybody that continues to be symptomatic after pulmonary embolus should be investigated, but not all of them are going to have CTEPH. And as you said, about 96% of patients will resolve their pulmonary embolus, and about 4% are left with residual abnormalities, some of whom are going to have CTEPH. And by and large, we sort of work on the general premise that about 4 per million of population, this is our population information, 4 per million are going to end up with CTEPH.
So what happens in patients that do develop CTEPH, David? Obviously they don't quite resolve their clot or the thrombus, in the pulmonary artery, but something else happens that really kind of triggers this vascular reaction, this thickening of the blood vessel in the pulmonary arteries.
So it's sort of we have this sort of handy way of thinking about it that the clot doesn't dissolve, it lodges in a bifurcation point, propagates down the segmental, subsegmental vessels, and then turns into scar due to a cicatrization process. So you get fibrous tails and blind pouches and webs and bands and so on, and then that's CTEPH. It's probably not quite as simple as that. And that, as you just mentioned, you probably need some sort of second hit, but nobody knows what that is, to start off the process of cicatrization and scarring.
So some inflammation involved or an immune response, what makes, basically you have a clot that is, so it can be in the very large segment of the pulmonary artery or maybe in some of the segments, but then you get some really thickening of the walls of the pulmonary arteries, way down distal near the alveoli.
Yes,
how does that happen?
Yes, we know that second hit is not known.
Yeah. Well, it's obviously a very difficult. Presentation can be so variable. As a matter of fact, if you see a patient with CTEPH, about a quarter or 25% of them have never had a history of a blood clot at all. So what is what should cue us in, to tell us, well, maybe this patient could have, CTEPH. If we're in the practice, for example, of seeing somebody that's short of breath, what is the frequent presentation of these patients?
So let me just backtrack a little bit about who should be investigated after pulmonary embolus. So you can't investigate everybody. You'd be doing so many VQ scans and CT scans and so on. That would be unmanageable. But I think there is a very, very good screening test for patients that have had a pulmonary embolus and separates out that those who don't need further investigation and those that do. And the screening test is easy. You get the patient in the office about 3 months after the pulmonary embolus and you say to them, are you back to normal? Can you do everything that you did prior to the pulmonary embolus? If the answer is yes, those patients don't need screening. If they say no, those patients need screening for sequelae of a pulmonary embolus. Now, the problem with chronic thromboembolic pulmonary hypertension, firstly, let me give you the definition of CTEPH. This is the international Nice Symposium definition, because it's recently been revised. And that is a mean PA pressure of greater than or equal to 20 millimeters of mercury. It used to be 25, it's now ratcheted down to 20, with a wedge pressure of less than or equal to 15, with a PVR, pulmonary vascular resistance, of greater than or equal to 3 Wood units. So that's the now accepted definition. So the problem with the diagnosis is it's very, very insidious. And it by and large, it takes about 4 visits to a general practitioner and 4 visits to a specialist to make the diagnosis, because it's attributed to something else. And it could be heart failure, some chronic lung disease, there's many different diagnoses that it could be misinterpreted as. So frequently these patients turn up very late, already with severe right heart failure.
It's very difficult, David, because only 75% of these patients will have a confirmed PTE prior to presentation. Barely half of them will have a history of DVT. And maybe a third of them will come to you for a repeated PTE. That means it's not, they've had, more than once. So, but I think your point is very well taken. If you do have a history of a blood clot somewhere, whether it's a DVT or whether it's a PTE or pulmonary embolus, this post PTE syndrome, or this, post embolic syndrome of still not being back to your normal self, still being short of breath is very, very important. It should cue us in to do a little further investigation, and probably, the best and the cheapest, maybe that VQ scan, which we could do as an outpatient.
Yes, but if you're completely back to normal,
right,
you don't need it.
Yeah. Well, what are the risk factors to develop CTEPH, Jason? Are some patients more predisposed to develop chronic thromboembolic syndrome?
Yes. So there are risk factors, just like with a lot of things, for developing chronic thromboembolic pulmonary hypertension. We talk about often a kind of one hit with the pulmonary embolism. But there can be additional things that can weigh against your favor if you have that could predispose you to the development. So part of that with that acute setting, if you have recurrent pulmonary embolic events, that can increase the likelihood of very large perfusion defect. So kind of the burden, if you will, can sometimes make you at higher risk for developing a higher pulmonary artery pressure at the time of the initial pulmonary artery of the PE diagnosis. So if you already have kind of existing chronic pulmonary hypertension, this would be potentially kind of the second hit that you have that would then kind of create that as well. An unprovoked pulmonary embolism, so having some underlying issue that we didn't know about. So the unprovoked patients seem to develop the CTEPH at a higher percentage. So some blood factors or hemostatic risk factors, if you have kind of blood coagulation disorders that predispose you to developing thrombus, those are something that kind of, again, increases your chances for developing CTEPH. Other types of antibody issues like with lupus or antiphospholipid syndrome, it seems that these patients with kind of these underlying issues can develop CTEPH at a higher percentage than the regular population. And some associated medical conditions that can also do that as well. So prior splenectomy can do that as well. Chronic inflammatory disorders like your rheumatoid arthritis, even gout, some of the kind of chronic inflammatory issues, probably all inhibiting some of the natural factors that break down clots, predispose to CTEPH. There's also some evidence that hypothyroidism and underlying malignancy can as well. So there are some underlying kind of patient factors that can predispose or increase the likelihood of developing chronic thromboembolic pulmonary hypertension. So those are all things that your physician will kind of keep in mind when evaluating you in the office.
Very good. So unprovoked pulmonary embolus, very important factor, as well as if the embolus is large enough to cause significant problem with the right ventricle, a large burden, as well as certain patient, like you mentioned. Is there something with hypothyroidism, David, that if you have a low thyroid, why should that make you more prone to develop, CTEPH?
I'd actually never heard of that before.
Never understood that one. I guess if you're hypothyroid,
that went up on me there, Jason. I've never heard that one before. But many of the things that you've described are risk factors for pulmonary emboli. But what makes it progress to chronic thromboembolic pulmonary hypertension? Well, that's what we don't understand. And there are no doubt, there are likely genetic abnormalities with fibrinolysis so you make abnormal clot and the lytic mechanism's abnormal. So it's probably something along those lines.
So David, let's say, this patient goes untreated, you develop, CTEPH. What's the natural history? I mean, it's a pretty bad disease, isn't it?
Yes, it is. So the natural history is poor. And there's information from back in the 1980s, which is still sort of relevant. Although the landscape of treatment for CTEPH has changed with BPA, balloon pulmonary angioplasty, medical therapy, and pulmonary endarterectomy. So what was described back in the 1980s is probably still relevant today. So your survival is dependent on your mean PA pressure. So let's say your mean PA pressure is around about 50 millimeters of mercury. So by 2 years after the diagnosis, you've got about a 20% chance of being alive. So it's a very mortal condition.
Yeah, I mean, I guess if your normal mean PA pressure, probably around 12 to 15, so if your pressure is less than 20, your prognosis is very good. But, as you mentioned, the higher the mean PA pressure, 40 and 50, only 5 to 10%, will survive. That's a very, very deadly condition if left untreated. So, Jason, what is the workup, the classic or typical workup of a patient that you suspect CTEPH?
Yes. So, a lot of times, these patients' symptoms, as we've talked about a lot in these podcasts, shortness of breath, dyspnea on exertion, just kind of overall fatigue, not feeling well. These, unfortunately, symptoms can, happen with a lot of disease processes. So you by and large need additional information, and we largely have that. When we see patients, because these patients have been very miserable, people will order lots of different testing and different tests, and then things will usually kind of become abnormal, and then they'll eventually get to a specialist. So usually kind of the first things with kind of the signs and symptoms of pulmonary hypertension is usually where it starts with, right? That's how these patients initially get funneled, to expert centers. You do a, chest X-ray, pulmonary function tests, EKG, echocardiogram, kind of all the standard initial workup for someone with shortness of breath, looking at both the heart and the lungs. Generally speaking, what will happen is that the echocardiogram, so the ultrasound of the heart, will show pulmonary hypertension. So that's usually kind of the first kind of gateway, usually the first thing that is noticed, with the patients that's having these symptoms. So that will usually land someone into a pulmonary hypertension clinic or specialist, and then that'll start the cascade of events to evaluate that. And usually kind of the big gatekeeper for CTEPH is, as Dr. McGiffin talked about already, is the ventilation perfusion lung scan, or the VQ scan. So this actually looks at the perfusion of the lungs as well as the ventilation of the lungs, as the name suggests. And if there are segmental or larger unmatched perfusion defects, meaning you don't have, there's an issue with the flow and ventilation, and it's abnormal, then that will clue you in that there could potentially be CTEPH. Coronary thromboembolic pulmonary hypertension is the cause of the patient's pulmonary hypertension. Now, real quick, if it's normal, the VQ scan is very sensitive. So this is an excellent test, and we hold it in high regard. If you have a normal scan, then CTEPH, so chronic thromboembolic pulmonary hypertension, is excluded. Now, we'll get to this in later in the podcast. Post-PE syndrome, or what's often called CTED, or chronic thromboembolic disease, is different. So you can actually have a normal VQ scan, and then maybe have one of those other syndromes. But let's just talk about the pulmonary hypertension specifically. So if that's abnormal, then that would usually trigger the right heart cath. And as Dr. McGiffin suggested, mean pulmonary pressure greater than 20, a wedge less than 15, and the presence of an abnormal VQ scan will then kind of lead you in that diagnosis. Now, at that point, you need to determine if someone is a surgical candidate. So there are a couple different ways of doing that. One would be either catheter-based pulmonary angiography or CT-based pulmonary angiography. There are also some people, doing MRI as well. But for those two things, you basically look at the anatomy of the pulmonary arteries, and often with a surgical or interventional specialist to, kind of get a group multidisciplinary decision about how to proceed forward.
Everybody consider the CT or CTA of the lungs almost a gold standard for, detecting an acute pulmonary embolus. But, for CTEPH, I guess we're relying primarily on whether the patient has an abnormal VQ scan or abnormal ventilation to perfusion, defect. And it could be quite difficult, I guess, with the CT to detect a condition like CTEPH, isn't it?
No. There's a form of CT scan called dual energy CT, which is sort of relatively new, that gives you much more precise imaging of the pulmonary vasculature, and you can see the perfusion much better as well. So at the Alfred, we use dual energy CT scanning. For surgical decision making, we still rely on pulmonary angiography. Many centers have stopped doing it. You need some sort of angiogram. It could be an MR angiogram, a CT angiogram, and they're happy to make the surgical decision making on that basis. But we still do a catheter-based pulmonary angiogram. And how it's done is actually very important, because you've got to let the camera run on for at least about 7 seconds, so you can look at the perfusion of the lung to give you clues about where the holes are in the perfusion, and different views, so you make sure you don't have overlap of different vessels. Then you can get very exquisite pictures of the thromboembolic disease.
So is this what's called the SPECT CT VQ scan, or a combination of a tomographic picture of a VQ? The dual end.
CT scan with two energy sources. I'm not aware of all the physics of it, but they're able to resolve much better fine detail of the pulmonary vasculature with two X-ray beams.
So basically, for the workup, I mean, you need something to detect the pulmonary hypertension, which is the echo, and then the right heart cardiac catheterization. Then you need to be able to look at the vasculature, and of course, there you have the VQ follow the pulmonary angiogram, whether you do it invasively or non-invasively. I don't think we have a whole lot of experience with magnetic resonance imaging, but certain centers do that, on a regular basis. The same, I guess, with the CT angiogram. So David, let me ask you, what is your treatment algorithm? I mean, we know that these patients, I mean, the pathophysiology and the cause of their problems, the blood clots, so everybody's going to be on the blood thinner. But obviously, you're a surgeon, you're trying to decide, and this is a curable disease, you can cure them in the operating room. So what goes on, with the process of deciding, are they operable or are they not operable?
So there's another important aspect we haven't touched on yet that we need to mention, and that is microvascular disease is or can be an important component of the disease. So there's the large vessel obstruction from the fibrous cicatrization, but there's also microvascular disease, particularly if the disease has been going on for a prolonged period of time. That is, unobstructed areas of the lung are subject to these higher pressures and then excessive muscularization of the very, very small precapillary arterioles. So in other words, then there's two causes of the pulmonary hypertension, the macrovascular obstruction and the microvascular disease. And that's an important part of the decision making, because if the pulmonary vascular resistance is high, or the pulmonary artery pressure is high because of a lot of microvascular disease, with not a lot of removable surgical disease, then that's going to make the risk of the operation very much higher and perhaps prohibitively high. Now, I'm not suggesting that the patient can't benefit from an operation, but the end result in terms of reduction of pulmonary artery pressure won't be anywhere near as good as the converse, that is lots of macrovascular disease and very little microvascular disease. Unfortunately, we're really not able to have any reliable way of sorting out how much is microvascular disease and how much is the macrovascular disease responsible for the pulmonary hypertension. You can get clues about it. So somebody with just, let's say, systemic PA pressures and very little large vessel obstruction is going to have lots and lots of microvascular disease. And of course, the converse is true. So the decision making about the first thing is the most effective way of dealing with chronic thromboembolic pulmonary hypertension is an operation called pulmonary endarterectomy. That is what the goal is. Is the patient operable? Is the patient inoperable? And that decision needs to be made by an experienced multidisciplinary team. So one end of the spectrum, it's real easy. Lots of disease, pulmonary hypertension, minimal microvascular disease, no problem, easy. At the other end, the major component being microvascular disease with very little macrovascular disease, that patient is not suitable for a pulmonary endarterectomy. It's all the ones in the middle which can often be somewhat problematic, and that's why it needs an experienced set of eyes to look at all the information, because it's not just the pulmonary angiogram, it's the right heart catheterization, the echocardiogram, the VQ scan, all of that comes into this decision making. So you also have to bring into the equation all those things that we use when we're assessing patient for cardiac surgery. Do they have sufficient physical reserves to get through the operation and the post-operative period? Is the comorbidity excessive? Because many of these patients have comorbidity. Remember, pulmonary embolism is a disease of comorbidity. And so we've got to factor the amount of the amount of comorbidity into this decision-making equation as well.
Patient with cancer, patient with diabetes.
Right, exactly. And but more important and germane to CTEPH is, what if somebody's been missed for a very, very long period of time, and by the time they turn up, they've already got renal failure and hepatic failure, and that's not common, but it's not uncommon either. So all of those things need to go into the equation. And when you're looking at it from a surgical perspective, you've got to be thinking, and just this is a general heuristic now, you've got to be thinking surgically, how much lung am I going to give back to the patient? By and large, this is sort of my heuristic really, can I give the patient a lung back? In other words, can I remove enough thromboembolic disease to give them back perfusion to a lung? Now, it might be, a bit here and a bit there and so on, but it all adds up to about a lung.
Well, the clot burden, as you mentioned, is very important. Need to make sure that the hemodynamics are also factored in. If the pressure is out of proportion to the clot burden, that means pointing toward small vessel disease, microvascular disease, as you mentioned. Patient factor, as you mentioned, the comorbidities, and the surgeon and the center that you're going. So, if you look at your goals, David, I mean, obviously you want to save a life, but you want to, what are your goals? I mean, you're trying to improve symptoms. As you mentioned, you're trying to get their lungs back. I heard you say in the past that talking about the dead space. Can you tell us a little bit more about that?
Yes. Patients can be symptomatic for a couple of reasons with CTEPH. They can be symptomatic because they've got severe pulmonary hypertension and all the consequences of that, with right heart failure and low cardiac output and so on, all those symptoms we know of. But in CTEPH, there's another important cause, and that is dead space ventilation. So patients are ventilating areas of lung that are not being perfused, and that can make you very symptomatic. And it's the patients that wake up after a pulmonary endarterectomy and suddenly that they can tell straight away that they can breathe. Their breathing is much better. Usually they're the patients that have got dead space ventilation that's been relieved.
Obviously, you're going to improve hemodynamics. Sometimes you have the right ventricle, which is quite large, and even, the walls are thicker and hypertrophic. I mean, is that a contraindication to surgery, or that's not necessarily makes you back out unless you had problem with liver failure?
Oh, no. There is no degree of right ventricular dysfunction that would make a pulmonary endarterectomy contraindicated. Certainly in our hands at the Alfred. In somebody who that you're going to get a good hemodynamic result, that right ventricle is going to get better. And you can see it on the operating table. You can see the right ventricle shrink down. Just as you can see that after a lung transplant for pulmonary arterial hypertension on the operating table. The heart can be very, very different at the end of the operation. So that's how quickly this reverse remodeling process can start. So no, there's no degree of right ventricular dysfunction that would dissuade me from a pulmonary endarterectomy in a good surgical candidate.
Right. I can see how the right ventricle is going to be happy to pump against pressure that are 20 millimeters or less versus 40 or 50 millimeters of mercury. That's quite an afterload that you eliminate right away.
Yes, you don't get that sort of hemodynamic result straight away. You can immediately after the operation, in the operating room, the pulmonary artery pressures may be very much lower because you've removed the impedance to ejection, but that PA pressure continues to fall. at 24 hours after the operation, it's lower again than what is in the operating room.
Amazing.
And the other question that's important to mention is that when do you make a decision about reinstituting pulmonary vasodilator drugs after a pulmonary endarterectomy? And who needs it? So you should not make that decision for reinstituting pulmonary vasodilator drugs until about 6 months after the operation. So all patients after pulmonary endarterectomy should have a right heart catheterization about 4 to 6 months after the operation. And the trigger for restarting pulmonary vasodilator drugs because of the persisting microvascular disease is a mean PA, PA pressure of greater than 30.
Well, that's great, David, but you're going too fast for me. Right now, I'm still in the OR. Let's say you're a patient with CTEPH. What happens in the OR? I mean, is this like a minimally invasive? Is it sternotomy? Can you tell us a little more about the operation itself?
Right. So the operation, at least in most people's hands, is a sternotomy. There is a bit of interest in a minimally invasive approach, but that's not something that I've embraced. So cardiopulmonary bypass, standard cardiopulmonary bypass, but you have to cool the patient down because one of the components, pathological components of this disease is collaterals. And the collaterals can be often very, very pronounced. So if you're getting into the pulmonary arteries to remove all this disease, if you have any flow with the heart-lung machine, you are absolutely not going to see a thing. So the operation has to be done at circulatory arrest. So we cool the patient down to a nasopharyngeal temperature of 20 degrees centigrade, and we monitor the cerebral perfusion, and mind you, at 20 degrees centigrade, the brain's really not doing all that much. We have a neurologic protection strategy, thiopentone's given and so on. Some people put, encase the head in ice, but that's probably just cooling the scalp, not the brain. And then we arrest the circulation, so then we can take all the blood out of the pulmonary arteries, so we can get in there and tease out all this disease. And then we reperfuse the patient at the end of 20 minutes for 10 minutes, and then circulatory arrest again. So 20 minutes arrest, 10 minutes reperfusion. And that's a very safe strategy from a neurological protection angle.
So in 20 minutes, you can do a whole lung. You'll do the left lung to start with.
Yep.
And obviously, this is not embolectomy like you do in the acute pulmonary emboli. This is really thrombectomy, which is really what do you do exactly? You dissect the artery.
The critical thing is to be in the right plane, and the right plane is not at the what you might think intimal level, because there's really no intima. The intima is just all fragmented. Where you are is actually in the wall of the pulmonary artery, about a third of the way into the pulmonary artery. Now you think how thin the pulmonary artery is compared to the aorta. So you've got to know that you're in the right plane. Now there are clues that tell you that you're in the right plane, and then you have to follow this plane of dissection out as far as it'll go. And the important thing is not what's happening in the large pulmonary arteries in terms of obstruction, it's what's out in the segmental and subsegmental pulmonary arteries, where you have these fibrous tails. You've got to follow them all the way out and tease them out. That's what's going to make it an effective operation hemodynamically.
So you're pulling gently on this, fibrotic clot, system, while dissecting the wall. I can see how easy it would be to get a perforation, and pulmonary hemorrhage, afterwards.
Yes.
How frequently does that happen?
Very infrequently. I'm not the one to be talking about massive pulmonary hemorrhage because I've not ever seen it. But, having said it, one day it's going to happen. But generally speaking, it's a tear in the pulmonary artery branch because in your dissection, you probably got a little too deep, went through and didn't recognize it. And so once the patient's reperfused, there can be, a huge amount of blood come up the endotracheal tube.
So that's the problem. I mean, you work bloodless, and you can only find out, once you're done with the surgery on that lung, when you kind of rewarm the patient, and probably sometimes even when you're done. That must take you talk about 20 minutes on the right lung and 20 minutes on the left lung, but obviously with all this rewarming, and how about if you're a large patient, it takes a lot longer to rewarm, and it could be several hours in the OR.
Yes, it could, absolutely. It could take up to 3 hours for rewarming, particularly in somebody who may weigh 300-400 or more pounds. It can be a very long rewarming period.
I heard you operated on a patient once that weighed 450 pounds and took several hours to rewarm. And
yes, it was
very challenging.
450 pounds is correct. I can't recall the duration of rewarming, but it was a long time.
Well, obviously this is a great surgery, and you can cure somebody their problem. There can be some complication. Obviously, the mortality is not zero. What kind of problem can you expect with sometimes with the lung developing some edema or some fluid developing in the lungs, or sometimes neurological issue, bleeding issue? What kind of complications can you expect?
Yes. Well, there are the usual risks that we see after any form of cardiac surgery in high-risk patients, particularly those coming to the operation with renal dysfunction and hepatic dysfunction. But the ones that are specifically germane to the operation of pulmonary endarterectomy, the complications can be pulmonary edema, a reperfusion pulmonary edema. Now, that's always talked about. It's a sort of a reperfusion injury that's sort of not all that different from what we see after lung transplantation sometimes, it's sort of a reperfusion edema. Having said that, it's actually very, very uncommon these days to see a substantial reperfusion pulmonary edema. So most of the mortality is related to massive pulmonary artery hemorrhage because there's been a tear that hasn't been recognised. There are lots of ways of dealing with that, and it all happens in the operating room. But the way it's managed is to try and decide which lung it is, and put a bronchus blocker in, and put the patient on ECMO. And odds are that tear, if it's not all that big, is going to just clot off. And with a massive pulmonary hemorrhage, it would be pretty unusual these days to result in a patient's death. Persistent pulmonary hypertension, that is lots of microvascular disease. Perhaps the amount of microvascular disease was underestimated, and there wasn't as much macrovascular disease as was predicted. And so the patient comes off bypass. There's still severe pulmonary hypertension. Maybe the PA pressure might be the same, but you've increased the cardiac output because of the disease that you've removed, but it's still a problem because the right ventricle is still being able to ask to do something that it's really not capable of pumping against. So persistent pulmonary hypertension can be a serious problem, serious enough to require VA ECMO. And then there are all the usual things about renal dysfunction afterwards. It's not uncommon to have oxygen requirements for some time after the operation, because you've created a shunt, because you've got uncontrolled blood flow in an endarterectomized segment of pulmonary artery. So now you've got excessive blood flow for the ventilation, And so patients can be quite hypoxic. And I have seen that hypoxia severe enough to require VV ECMO for a period of time. But then that need for additional oxygen will eventually disappear.
So, and we're going to talk to Jason in a little bit about this persistent pulmonary hypertension, which can occur between 15 and 20% after the surgery. But all of this point to the importance of seeking a surgeon who's done a lot of these procedures and seeking a center that is a referral center for CTEPH. I mean, obviously, the more procedures you do, there's an inverse relationship with mortality, isn't it, David?
Yes, that's correct. But it's not only the operation itself, but it's the decision-making surrounding the operation too. Which patients are suitable and which patients are not suitable for pulmonary arterectomy. And a program that has a very small volume is going to be understandably conservative. And there will be patients that don't get an operation that really should.
Yeah. So I guess if you're were labeled inoperable, it would be worthwhile to get a second opinion, particularly in a center that does a lot of them.
That's correct.
Tell us a little bit about the post-op care, David. Someone has had a surgery for CTEPH. You extubate these patients early. How long did they stay in the hospital? What kind of treatment are they on after their operation?
Yes. So once again, there's a spectrum of the course of a patient after pulmonary endarterectomy. At one end of that spectrum, there are patients that have a dramatic hemodynamic response, and those patients we wake them up. Now they take a little longer to wake up because they've had a pretty deep anaesthetic and they've had thiopentone as part of the neurologic protection strategy. So by the next day they're awake, and we'll often get those patients extubated 24 hours after the operation. But at the other end of that spectrum, where there's patients who have persistent pulmonary hypertension, they've got right ventricular dysfunction, those patients we take much slower. And so there are patients that really struggle. This is very uncommon these days, and really that is predicated on making the right decision. There are patients that can struggle that might need VA ECMO. We've had a patient recently that we had to actually, because of severe persistent pulmonary hypertension from severe microvascular disease that we underestimated, we had to get them on VA ECMO and bridge them to lung transplantation. Now, that's the first one that we've ever had at the Alfred, but it is emblematic of the fact that there is a big spectrum, and at one end of that spectrum, these patients can be really critically ill. You have to think about other things such as lung transplantation and reintroducing pulmonary vasodilator drugs early to try and bridge the right ventricle through this period of circulatory instability.
These patients, if everything goes well, they stay in the hospital a week or two, and then what is the time that it takes to become fully functional and go back to work and so forth?
Yeah, at the good end of the spectrum, patients doing convalescing very well. They're anticoagulated with warfarin. Anybody with a pulmonary endarterectomy needs to be on warfarin, lifelong warfarin. The DOACs, which might have been used for the pulmonary embolus, should not be used after a pulmonary endarterectomy, because those drugs have never been trialed in post-pulmonary endarterectomy patients. So it's lifelong warfarin and with an INR target of 2 to 3. Now, in somebody with perhaps a higher risk of pulmonary emboli, particularly somebody with antiphospholipid syndrome and so on, your INR target would be higher. But for everybody else, the target INR would be 2 to 3. So these patients really, at that end of the good end of the spectrum, they're like somebody who's had cardiac surgery for any other reason, coronary bypass surgery, valve surgery, so they go back to work. based on the usual criteria for cardiac surgical patients.
What do you do in the patients that had severe pulmonary hypertension and they were all on the drugs that Jason, gives, the iloprost, and do you actually discontinue these medications afterward, or it depends on their pulmonary artery response?
Yeah, we discontinue them. And unless, of course, they're at the difficult end that patients are clearly having hemodynamic instability from persistent pulmonary hypertension. That's a whole different group. But for the majority of patients, those drugs are discontinued, not restarted. Right heart catheterization 4 to 6 months after the operation to then make a decision about reinstituting pulmonary vasodilator drugs based on persistent microvascular disease.
You mentioned sometimes patient can have neurological deficits. I mean, obviously, there's no circulation to the brain for 20 minutes twice, times two. I hear some patients really get some good effects from that and come out of the surgery smarter.
Oh, never heard that one before. No, I've never heard that. But neurologic, they might be a little slower to wake up and a little bit confused, but a permanent neurologic deficit, that would be incredibly rare. 20 minutes of circulatory arrest at 20 degrees and isoelectric EEG, your brain doesn't do too much at that temperature. It's a very safe strategy.
Wonderful. Now let's talk about the patient that was labeled non-operable. What kind of medical therapy, what kind of other strategy can we use in these patients? And we hear a lot, particularly from Japan, about pulmonary balloon angioplasty. So tell us a little bit about that.
Balloon pulmonary angioplasty is a really interesting new development. It would be incorrect to view balloon pulmonary angioplasty as competitive with pulmonary endarterectomy, but it's really complementary. Balloon pulmonary angioplasty is a very good strategy for patients that are inoperable for whatever reason. It might be because of comorbidity, lack of physical reserves. Usually it's not, it's those patients, let me just backtrack a minute. It's also useful for patients that are inoperable because they've got mostly microvascular disease and little macrovascular disease. But some good targeted BPA, though, can really help patients hemodynamically and symptomatically. Now, the other place for BPA is patients who have persistent disease after pulmonary endarterectomy, where we got an inadequate, incomplete clearance and are still symptomatic. So it's very useful. The problem is that it takes several sittings. You can't do the whole pulmonary vasculature in one sitting because, there are risks associated with risks of hemoptysis and damaging a vessel and perforation. So it's got to be done in expert hands. But it is complementary to pulmonary endarterectomy. The management of these patients should be predicated on the idea that pulmonary endarterectomy is the best option. And balloon pulmonary angioplasty is a complementary therapy for inoperable patients and patients with persistent disease after pulmonary endarterectomy.
Yeah, certainly when the pulmonary artery is completely occluded, it's difficult to treat even with balloon angioplasty, although some centers in Osaka, Japan are doing them. Most of the time, it's when you have a pulmonary artery stenosis or narrowing of the artery, when you're talking about subsegmental, arteries. Sometimes they could even create a bruit over the lungs. I've never heard of that of all my years of examining patients, but I don't know if you had ever heard, a bruit over the lungs of the patient caused by a narrowing of these pulmonary arteries. Maybe.
No, I've never been able to hear that.
Apparently, up to 30%, you have to be looking for that. But
you really would.
As you mentioned, several sessions. I mean, obviously, you reopen an artery of the lungs, bringing a lot more blood, and could cause some revascularization, hemorrhage, and they have to come for 3 or 4 sessions, contrary to surgery, which is done in the same setting. Here you have to come back to the hospital for about 3 or 4, different sessions on reopening your arteries. Certainly, it's got to be. I think Mustafa did a few at UAB, but it's not very common. But there's still medical therapy, Jason, and there is this medication, riociguat, which has been approved particularly for patients with group 4 pulmonary hypertension. Can you tell us more about some of the results with that?
Yes. So, medical therapy, like for a lot of things, is always an option for a lot of patients. So for CTEPH specifically, when patients are, technically inoperable or operable, but with an unacceptable risk-benefit profile, like Dr. McGiffin talked about, or if people have kind of residual pulmonary hypertension following a PT surgery, medical therapy is a very reasonable option. Now, by and large, we kind of treat, these patients kind of like our kind of standard pulmonary hypertension patients, but with a few little differences. You've suggested one. So riociguat or Adempas is a medication that kind of has that label for patients with CTEPH. It is a soluble guanylate cyclase stimulant, kind of in the same class as the nitric oxide pathway, similar kind of pathway that the PDE5 inhibitors work on. So this trial was the CHEST-1 trial. So there was 2 trials, CHEST-1 and CHEST-2. So CHEST-1 was a randomized double-blind placebo-controlled trial that improved the PVR, pulmonary vascular resistance, and the 6-minute walk distance after 16 weeks in the patients with CTEPH. So CHEST-2, which was kind of a follow-up extension trial, showed persistent efficacy for up to a year. So that was, kind of what really landed riociguat kind of on the map in the pulmonary hypertension world, specifically for the WHO Group 4, which is the CTEPH that we're talking about, although it's also used in, WHO Group 1 as well. So there are other medications as well. Riociguat kind of gets that gold star, so to speak, for that indication. But kind of moving down the line with the other classes of medicines that we've talked about previously in the other pulmonary hypertension podcast, also have some data as well. So the PDE5 inhibitors, sildenafil and tadalafil, there's been kind of pilot studies, looking at those at reducing pulmonary vascular resistance. So those can be used, obviously not in addition with riociguat. They're kind of all in the same similar family. But the endothelin receptor antagonists, or ERAs, specifically macitentan and bosentan, have all been shown in kind of small clinical trials in CTEPH to be helpful. So for macitentan, the MERIT-1 trial, which was a randomized double-blind placebo-controlled trial, improved PVR at 16 weeks. So there is some data with those medications and those classes of medications in CTEPH. And then lastly, your prostanoids that we've talked about before. So epoprostenol, iloprost, and treprostinil all have kind of data with inoperable CTEPH patients. So they, kind of have their own trials looking at, reducing PVR and improving exercise capacity. And specifically treprostinil in an uncontrolled trial with severe inoperable patients improved PVR after 20 months and actually had a higher 5-year survival rate. This was compared to historical controls. So all these medications that we use in your WHO Group 1 patients, which we've talked about previously, all have a role in treating these CTEPH patients as well when, surgery is not an option or when patients have residual pulmonary hypertension after the surgery.
David, you've had some good success with the medical therapy in some of your patients that are inoperable?
Yes, but the substrate is still there for progression of the disease and progression of the subsystem dysfunction too. So yes, they can be improved, but what we try and do is if we can identify some BPA targets, then we will certainly start this specific pulmonary vasculitis, but we will do whatever we can to use BPA.
So What about the future? Is there any research that is being done in CTEPH, surgical research, as well as or other means of treating these patients, particularly if they're inoperable?
Well, I think there's, at the moment, the directions are, the operation of pulmonary artery is sort of well worked out, but the direction we're sort of going at the moment is how distally can we go? And how distal can the disease be and still be operable, as opposed to it starts proximally and we can work our way out and remove the distal disease. If it's all out in the distal subsegmental branches, are they still surgical targets? So that's something that's being done in experienced centres. And I think one of the other directions, of course, is the sort of jockeying for position of pulmonary endarterectomy, BPA, and medical therapy. At one time, they were sort of non-overlapping therapies, but now they're sort of becoming very complementary, and we just sort of got to find out what the relative role is of these three different therapies. And of course, one of the other areas is there's got to be, well, it's very likely there's genetic basis for the inadequate, incomplete fibrinolysis and abnormal clot formation, and it's trying to find those genes that might be responsible that underpin the development of CTEPH.
Well, certainly, I guess it's like the heart team approach, where the surgeon works, with the interventional, cardiologist or pulmonologist, and have this approach where you would do surgery and followed by balloon angioplasty to have maybe a more complete, some kind of hybrid, approach to the CTEPH patient, and then complemented by medical therapy. Totally see that as working together.
It's absolutely critical that this is a multidisciplinary approach. That's the best way of getting the best results in CTEPH, is that the management's decided in that setting.
Any comments, Jason?
Yes, on the medical side, we've got some clinical trials. One specific one is the ongoing RACE trial. So this is riociguat versus balloon pulmonary angioplasty, or BPA, in your non-operable CTEPH patients. So this is addressing the question of comparative benefit of riociguat versus BPA for inoperable CTEPH. So this will be interesting. So kind of, again, teasing away, the BPA medical therapy, kind of a paradigm, which is best for which patients. So lots of interesting stuff. As you might imagine, these trials are usually slow going and they're small, because the patient population is small. But as we kind of determine and figure out, the surgical techniques, the percutaneous techniques, and then the medical techniques to take care of these patients, it's an exciting field to be in.
Certainly, I was surprised to see some of the long-term results with the balloon angioplasty with very minimal restenosis, which is something that we don't know much about. And on the arterial, the circulatory arterial side, where just balloon angioplasty leads to restenosis in 40 to 50% in some cases, but not in the pulmonary tree. Well, I'd like to see, obviously this is a curable disease when you kind of move to surgery. And I guess the earlier you can move to surgery, the better it is. And certainly you should not really postpone a surgical intervention just to see whether the patient responds to medical therapy or not. And how about the condition where you have the clots or the thrombus in the pulmonary arteries, but your pressure is still normal?
Yes, well, this is a relatively new diagnosis called CTED, as Jason mentioned, chronic thromboembolic disease. So they have resting normal pulmonary artery pressures, but they will, on exercise, those pulmonary artery pressures will rise. And those people can have substantial thromboembolic disease, but they can still be very symptomatic, and probably because of dead space ventilation. And so in experienced hands, the risk of pulmonary endarterectomy is extremely low, and those patients can benefit very substantially symptomatically from pulmonary endarterectomy.
You had some of these patients like this, Jason?
Yes, I have, and you really feel for these patients. Post-PE syndrome and CTED is actually kind of a growing awareness, which is always kind of in these rare diseases. These types of things always take time for people to become aware, and to have a critical number of patients where you kind of notice these kind of patterns, and then the field begins to kind of take notice as a field. It's actually a fascinating disease process. When you talk about circles, kind of the big circles are all patients with a PE, which we've talked about before, just a few percent, we're anywhere from 0.5% to 3% get full-blown CTEPH. That is just kind of the very kind of tip of the iceberg. There's a lot of, overlap in between there. These, patients with, symptoms of reduced functional status that you can't put your finger on. People are patients with persistent thrombi, and then patients with kind of measurable limitations in cardiopulmonary function that are still very symptomatic and largely kind of provoked by exercise. So this has been one of the main things that exercise right heart caths, or right heart cath with exercise, has kind of risen towards the top for kind of differentiating. So a lot of these patients are fine at rest, or relatively fine at rest. It's really when they exert themselves is when they have these issues. So as we know, exertion or exercise, we believe, limitations there kind of forecast or foreshadow, developing symptoms potentially at rest. So being able to identify whether it's, heart failure or pulmonary hypertension or CTEPH, being able to identify these things ahead of time or during exercise allows us to maybe treat them earlier so they don't develop resting symptoms. Now that's all kind of theory and hypothesis. But justifying the reason for kind of using exercise to kind of provoke symptoms. Now it's still kind of a difficult thing. As you might imagine, people don't agree necessarily on how to treat it, what to do about it. But I do think that even having a diagnosis, being able to kind of tell a patient, that and I say this all the time, hey, you're not crazy, because a lot of times people, the echo's normal or near, everything's normal, and physicians kind of get frustrated because the patient still has significant symptoms. So and the patients get frustrated, so be able to tell them that, yes, I believe you, your pulmonary artery pressures go very high when you exert yourself, and that likely causes your your symptoms. So you kind of give them a little bit of reassurance that you kind of understand what's going on. Now the treatment for that is a little bit more tricky, whether or not it's surgery or BPA or medications. That is still that we don't know the answers to that. We're just now realizing that post-PE syndrome and CTEPH is an actual entity and something that needs to be taken seriously. Next is going to be studying it further and determining treatment. I will say that, kind of small, meetings, that sort of thing that I've attended, and, with large group discussions, there are people that do treat it. So if you can prove, that someone has, elevated PA pressures with a normal wedge when they exert themselves, then they have been treated. And usually the medicine that we kind of reach for is riociguat. That's kind of the first line. And just start these medicines kind of very low and go very slow, and see how patients do. I've had a handful of patients, in exact this situation. We've had, 2 or 3 of them actually improve, pretty dramatically with pulmonary vasodilators. And we've had a couple that, really have had no change in symptoms. So, it's a very kind of inexact science. I think a lot of times in medicine, you just kind of try and provide patients options, obviously limiting expectations, but if they get a benefit, from these medicines, then that's great. And if they don't, then you stop the medicines and, wait for more information to kind of trickle in, from research. But I find this, Dr. McGiffin, you can, chime in as well. I find this very fascinating, this post-PE syndrome and CTED, how to diagnose it, pathophysiology behind it, how to treat it. I think it's going to be a very interesting, kind of field, so to speak, an offshoot of CTEPH, in the next few years.
So, Jason, these patients have normal pulmonary pressure, but they do have clots in their pulmonary arteries, so their VQ scan is not normal, right? I mean, this is not a negative VQ scan.
They have mismatch perfusion defects.
Right.
Yeah. So this is sort of this is CTED on the way to CTEPH, most likely.
So when you get a report, for example, of a low probability for PTE, that's not a normal. These patients could still have a VQ scan with that kind of report, couldn't they?
No, they'll have mismatched perfusion defects. If you've got a normal VQ scan, you don't have CTEPH or CTED. But if you've got mismatched perfusion defects, then there's a very high probability you've got CTEPH or CTED.
Yeah, there's an interesting kind of patient subset, patients that have historically, previously had pulmonary thromboembolism, where their, VQ scan actually can be normal, but they had this history and they have all the kind of same symptoms as people that have CTEPH.
Yes,
so this is that's
correct.
Yeah, this is a very interesting subset. So, I mean, people believe that these patients, kind of have abnormal thrombus remodeling, maybe even within the pulmonary arteries, kind of a dysfunctional inflammatory response, blunted angiogenesis, smooth muscle hypertrophy, some sort of, insult, these clots, got into the arteries, resolved or not resolved, and left some sort of lasting impression, so to speak, on the pulmonary arteries. That isn't necessarily always detected by the VQ scan, nor is it actually, even always seen on a pulmonary angiogram. So the arteries themselves, after the clot's been long gone, have, developed dysfunction. Now, whether or not it's solely from the clot or maybe this patient had a predisposition to pulmonary hypertension, but there's something there that isn't at rest, that is, provoked with exertion or with exercise. And, these, kind of patients fall under that umbrella, probably even more of a kind of gray area. But these are patients that, people talk about, in PERT meetings and pulmonary embolism meetings, as well as PH meetings, this kind of very sad, patient subset where, there isn't really anything identifiable on imaging or anything, but clearly have symptoms and clearly have abnormal hemodynamic responses to exercise. So what you do for these patients is, very tricky. But
you anticoagulate? Do you anticoagulate?
So that's a good question. So no one really knows, and I'll tell you that I do, because I wonder, and that'd be interesting to hear, David's perspective. All of these, imaging modalities, even though nuclear medicine is very sensitive, you got to imagine that at the very capillary, at the smallest level, maybe these imaging techniques, definitely pulmonary angiograms would miss some of this distal vessel stuff, kind of like akin to small vessel disease with a coronary angiogram, the so-called syndrome X. You have this kind of slow flow in the coronary arteries, and you don't see any blockages, but you can just imagine at the very small capillary level, there's, diabetic end products in there or other things that cause this slow flow. And even though you can't see anything, you can believe that this patient would have chest pain or have some sort of, chest pain type syndrome. So I kind of liken it. Of course, this is just me. Now I'm just kind of off on a tangent. So you kind of imagine maybe that's going on the pulmonary arteries, right? So you have these kind of this insult, this very, very distal kind of, still precapillary issues, that cause, low flow, maybe impaired gas exchange, especially if you're exercising, when you're trying to, get increased cardiac output through the pulmonary vasculature, that causes limitations and causes these patients to be short of breath. So that's kind of, once again, I've said this before, why this field is kind of exciting, because no one really knows. And there's lots of hypotheses. And, I kind of have even my own kind of stealing it from kind of the cardiology world that we live in. But I'd be happy to hear, your thoughts as well. But, some of these patients, I don't think you necessarily always see changes on VQ scan, but they've had a history of a PE, and it just makes you wonder if maybe that's playing a role.
Yeah, I think that's an important point, Jason. And as we mentioned earlier, not everybody that has ongoing symptoms after a pulmonary embolus has CTEPH. That's only a a proportion of them, and that there are these patients that have ongoing symptoms. They don't have CTEPH on a VQ scan, but they have some abnormalities that are still some abnormalities and symptoms, and they don't fit into the CTEPH CTED group, but we don't know what all that group's all about. But they can be very symptomatic, and we don't know how to manage them. And they're not patients that I see, actually. But I certainly know that it can be a real diagnostic and therapeutic conundrum.
You operated on the CTED?
Yes. They can be very grateful patients, because often CTED patients can be very symptomatic due to dead space ventilation.
Yeah. Well, gentlemen, I think this probably will wrap up our segment on the group 4, CTEPH, patients with chronic thromboembolic pulmonary hypertension, a curable disease by this incredible surgery with thrombectomy and remodeling of the pulmonary arteries, something that is difficult to find, and you have to sometimes, in the workup of your patient, rely on a very simple test like the VQ scan to lead you in the right direction. Curable disease, that's not very often that we see that in medicine. David McGiffin, thank you very much. Jason Guichard, thank you again for your great contribution on this podcast. Thank you, gentlemen.
To learn more from our team of cardiologists, please visit us at MyHeart.net. You can also follow us on social media by searching MyHeart.net on Facebook and Twitter. And be sure to subscribe to this podcast so you don't miss our next episode.